Rheumatic fever, an acute immunologically mediated multisystemic inflammatory disease seen in age group of 5 to 15 years most commonly. And the causative agent is group A streptococcus. Pathogenesis of rheumatic fever. With streptococcal infection of the pharynx or skin, antibodies and CD4 plus T cells are directed against the streptococcal M proteins, and these will cross react with host cardiac proteins. Antibody binding can activate the complement and recruit the inflammatory cells. Cytokines produced by the stimulated T cells will cause macrophage activation. Morphology. Pancarditis, that is pericarditis, myocarditis, and endocarditis as of bodies. Foci of T lymphocytes and occasional plasma cells and plump activated macrophages and angioscales are found in any layer of the heart. Evolution. It involves three stages. One is early stage or exudative or degenerative stage. The second is intermediate or proliferative or granulomatous stage. And the final one, late stage or healing stage or fibrous stage. Early stage. It is apparent by about 4th week of the illness. Initially, there will be edema of the connective tissue with increased ground substance, and later separated collagen fibers undergo fragmentation, causing the fibrinoid degeneration. Intermediate stage. It is apparent by 4th to 13th week of the illness, and infiltration with T lymphocytes, plasma cells, and angioscales is seen in this stage. Angioscales are the macrophages with abundant cytoplasm and central round to oval nucleus with condensed chromatin forming a central slender wavy ribbon caterpillar cells. Late stage, it is apparent by 12 to 16 weeks after the illness. Lesions become less cellular with an increase in the collagenous tissue forming a fibrocollagenous scar. Fibrinoid necrosis within the cusps or tendinous cords is seen. Small warty vegetations called as verrucae overlie the necrotic foci and along the lines of closure of the valve leaflets. Rheumatic heart disease. It is characterized by the deforming fibrotic valvular disease, and the sites involved for rheumatic heart disease are most commonest site is mitral valve, and the predisposing conditions are recurrent acute rheumatic carditis. Morphology. Gross McCallum plaques, which are irregular thickenings in the left atrium induced by subendocardial lesions, are seen in this rheumatic heart disease. Mitral valve shows leaflet thickenings, commissural fusion and shortening, and there will be thickening and fusion of the chorda tendinae. Calcification and fibrous bridging across the valvular commissures in mitral stenosis will create fish mouth stenosis or fish mouth appearance. Left atrium shows progressive dilatation with mural thrombus formation, and right ventricular hypertrophy will be seen in the late stages of rheumatic heart disease. Microscopy shows valvular post-inflammatory neovascularization and transmural fibrosis. Coming to the clinical picture, in acute rheumatic carditis, there will be pericardial friction rubs, tachycardia, and arrhythmias. Whereas in chronic rheumatic heart disease, we can listen to murmurs, cardiac hypertrophy and dilatation, heart failure, and arrhythmias. Jones criteria includes major criteria and minor criteria. Major criteria is migratory polyarthritis of the large joints, pancarditis, subcutaneous nodules, erythema marginatum of the skin, and Sydenham chorea. Minor criteria includes fever, arthralgia, elevated acute phase reactants in the blood. Diagnosis. Evidence of a preceding group A streptococcal infection with two major or one major and two minor manifestations helpful in diagnosis of the rheumatic heart disease. Investigations. Pharyngeal cultures, antibodies to streptococcal enzymes, streptolysin O, DNase B. Complications include thromboembolic complications and infective endocarditis. Do subscribe and press the bell icon if you found the video helpful and show your support.